Hi, I'm Dr. Micah Long. I'm a critical care anesthesiologist, and today I'll be tackling an important topic to me, which is the use of airway checklists in intubation emergencies. Now close your eyes. I want you to envision a story that happened to me. I was on airway call one day, carrying the airway bag, doing other work until emergencies happened. And the airway chimes went overhead, calling the airway team to a COVID ICU. That always hints a bit of fear in your heart, knowing that you're going to get exposed to COVID in a high-risk situation and that you're going to have to get all your PPE situated, and that adds to the time it takes to prepare to arrive to the emergency intubation. You get to the room, and while the physician at the bedside starts to tell you about the patient, you get your equipment ready, knowing you have to get it ready outside of the room. You can't bring that airway bag into the COVID room. You get everything situated, find out about the patient. They're horribly hypoxic, 85% at best, on 100% FiO2 with a high flow nasal cannula. Their respiratory rate is 40, sometimes 50 times per minute, and their work of breathing is intense. They were previously hemodynamically stable, but their blood pressure has been downtrending, still not on drips, but it's now 90/65, and things aren't looking very good. You get everything situated, including medicines, your equipment, and backup equipment, and you roll into the room, meet the patient briefly, and set yourself up to do the intubation. You push your induction, medication, drugs, and the next blood pressure that pops up as you're looking is 60/20. You reach for your phenylephrine you know you grabbed, and it's not there. You have to call out to the room, but in your PAPR and PPE is very hard for anyone to hear you, and you're going back and forth between yelling more and simply putting the tube in and running and getting it yourself. That story happens all the time, and it matters because these are preventable things that can go wrong. Emergency intubation that happens outside of the operating room is much more difficult than our operating room airways. The skills, of course, overlap, but when you're out of the operating room, you add in a host of different types of difficulty. Technically, the procedure has been shown to be much more difficult. This is related, of course, to the patients that you tend to be intubating in the ICU, who might have dry, sticky mouth, have other issues and cancer to their neck or throat. They may have been intubated recently, or swollen and edematous throughout their neck and face. The space you're working in is worse. Your difficult airway cart or other backup equipment is frequently left on the bed or outside the room. It's harder to get to, and if you call for help, it may not get to you quickly. They may have to run from the operating area far away, not from the operating room next door. The physical space is limited. You're in tighter quarters with a worse bed that's not made for intubating. Patients slip away from you, and the backboard has to be taken off. You put your knees on an uncomfortable bed. The vent is farther away. In addition to all of these things, the patients are physiologically unwell, and there's a phenomenon called physiologic difficulty. The patients are frequently not NPO. They're neurologically more prone to be agitated or simply to aspirate. Cardiovascularly, they may not tolerate the RV dysfunction that could occur with hypercarbia or hypoxia, or they may develop hypotension or low cardiac output from pushing induction medicines. And finally, they simply can't tolerate apnea. Not only are they probably riding the line of hypoxia and hypercarbia intensely, but they also are not preoxygenated well. They're prone to atelectasis, and things are simply not going well for their respiratory system, and that's the reason you are there. That physiologic difficulty divides your attention between a challenging procedure and fixing the complications that happen hemodynamically from your medicines as they go in and, of course, as they wear off. Retrospective studies that look at difficulties of intubation have been consistent in that they show that things are very bad when you are urgently and emergently intubating people outside of the operating room. They're more prone to severe hypotension or hypoxia. They're more prone to be esophageally intubated, and this happens six-fold higher than in the operating room. Even in patients you think were cardiovascularly stable, not needing boluses, not needing infusions of medicine with normal MAP, 30% of them become unstable once you go to sleep. I think of this as the stress response of being air hungry and unwell. The moment you put them to sleep and relax them, it's all gone, and everything relies on your medicines. This is a high number of people who do poorly after you intubate them. Meta-analyses and systematic reviews of this are consistent. Severe hypoxia, severe hypotension, up to a quarter of patients, with about 1 in 50 having cardiac arrest around your intubation attempt. We know that these difficulties are associated with complications, but they also lead to complications. It's not simply that unwell patients do badly around intubation. It's that unwell patients get physiologically unwell, and that divides the attention of the person intubating, and that divided attention makes you fail at everything. It's very, very hard to manage an impending cardiovascular collapse while grabbing your backup airway equipment and not delaying in your difficult airway algorithm. And you see here in the bottom left a wonderful figure showing that technical difficulty was associated with medical or non-technical complications like hypotension and things like that. This is the idea that there's a back and forth interplay between struggling with the airway and the propofol wearing off, getting hypertensive or waking up and vomiting, or having hypotension that demands or warrants your attention and not being able to intubate well because you're trying to divide your attention between a decompensating patient and an evolving difficult airway. Of course, we know that airways and intubation in general are not simply technical skills. Clinical experience may or may not play a role into your success. Of course, there is an aspect of technical ability and being extremely fast, and that only comes with a high amount of practice and volume with the procedure. But airways outside of the operating room particularly are normally in decompensating patients, and that requires the ability to lead the team, lead the room, to know when to lead and when to follow and listen, to help direct the volume of the room, and have the ability and medical knowledge to handle a whole lot of information, not only how to manage and manipulate their shock state, what to do, when to stop the difficult airway to manage their hemodynamics, but also the knowledge of what backup tricks are most useful to succeed with an evolving, challenging airway. And you, of course, need to be familiar with your induction agents, when they start, what their risks are, and when they wear off. Because airways outside of the operating room are in sick people in suboptimal environments, the group in France put out an intubation bundle to help people think through the immense number of challenges that can occur with intubation in a systematic way. This is one of the first publications of what I would refer to as an airway checklist. And you see, it's not just a checklist, it's really a to-do list. But what their group showed is when they rolled out this intubation bundle that simply ran through backup planning and making sure you have the right equipment and roles are assigned, things of this nature, you had improved outcomes shown on the right, both for markedly severe outcomes like arrest or severe hypotension and hypoxia, but also for your less severe complications. So using this bundle fundamentally improved patient care outcomes. Thus began a whole era of different airway checklists and approaches to intubating, both in the operating room and in the trauma bay, as well as in the intensive care unit. If you Google search airway checklist, a whole handful will pop up right away. I've simply listed the first few or most popular ones here, and what you notice about them is that they would be quite impossible to get through quickly. If you've ever shown up at an airway alone, you simply don't have time to get through this much information. You need to follow the ideas of Dr. Gawande, who wrote the Checklist Manifesto. Checklists are not made to be in-depth, how-to, comprehensive lists. They're not supposed to describe to you what to do. They're simply checklists. They make sure that you have made a mental note and developed a plan for several iterations of things that can go wrong. As expected, when we use these complex checklists, they don't pan out in the literature. This is a major publication that came out not too long ago that showed that checklists weren't associated with improvements. But it missed what I view as the most important thing inherent to this type of literature and study, which is that the people doing airways at a center that has randomized and trialed and researched how to intubate, they're good at intubation. They practice it. They've talked about this. They do it all the time. And what you see on the right is that most of the people, even when they weren't in the checklist group, were doing the checklist on their own anyway. In other words, whether or not you followed a scripted checklist, the checklist was being done every time by experienced people. And I'll note again that even in this study, the checklist was kind of a pain. I don't love this checklist. It takes a long time to get through, and it includes things like calculating a Makocha score, which, while a worthy academic pursuit, is a lot less important when I show up at an airway and I need to get the breathing tube in 3 minutes or less, and I cannot make a mistake the first time around. If we go back and think through what checklists should be, I think the book, The Checklist Manifesto, does a wonderful job of describing what an airway checklist should be. Although the book is mostly about surgical checklists, the applicability is, of course, simple and straightforward. Atul Gawande says that people think checklists make you rigidly adhere to a protocol, but that's not really the case. Of course, that is the case when you follow a checklist that circumscribes an entire sequence of events and scripts everything out like a comprehensive how-to guide. That's not what checklists are supposed to be. They should be simple, big text, easy to read references that you can glance at to not forget something. They should have few points, a few hits, not 15, 20, 30 checklist things. They should be easy to get through in a page, and they're meant, again, to simply be a cognitive aid, not a comprehensive guide to how to do something. At my hospital, I created a checklist called the TPMe Checklist. TPMe stands for team. I always encourage 2 leaders to be at every airway. Research has supported the idea that 2 people that know and speak the language of intubation help the patient lower complication rates. They help the provider, helping you feel confident. And when things go wrong, you get it much faster. P is for patient, position, and preoxygenate. When I think through a patient, I think of their physiology or past medical, and I think of their airway. Positioning is always done before you go to sleep, and preoxygenation can be an entire PowerPoint and presentation, but I think of it simply as this. You want to give as much oxygen as you can for as long as you can. Medications have subgroupings. I think of pre-meds for safety, a bolus or norepi infusion as a safety hedge against your induction agents, which is the next category. Induction agents and intubation is fairly straightforward. You're going to use ketamine, etomidate, or propofol. Finally, you could consider paralysis or not. I'm a believer in rocuronium, preferentially to succinylcholine, for again, varied reasons that could be an entire discussion. However, whichever one you pick or don't pick should be thought through. And finally, I make sure I have rescue medications like phenylephrine, ephedrine, or a norepinephrine infusion. Finally, the other M is monitors and equipment. Equipment is a lot of things. Of course, we have a lot of equipment intubating, and we have even more equipment when we include all our backup supplies. If you're simply learning how to intubate as a resident in any field, an early anesthesia resident, or anywhere in emergency medicine where you're not intubating all the time, going through a full equipment checklist takes a lot of time, and it's hard to do fluently. My approach has been to think through equipment in a order of use. First, you need an oxygen supply. PEEP valve, trauma bag, you make sure the trauma bag has oxygen flowing through it. You're going to try to mask the patient. It's not going to work. What are you going to do? You'll grab your oral airway. You'll put your oral airway in, and they'll vomit all over you. So you'll need suction. You might even need 2 suction for many critically ill patients having intubation done. You make sure your suction is where you can grab it without looking. Then, once you get all that nastiness out of the airway, you're going to try to intubate with the DL since it's messy. DL is not going to work, so you're going to grab your VL. You're going to see a view and try to put an endotracheal tube there, but it's not going to work. You're going to have to abort and put in an LMA. Do you have the right size LMA? And finally, that's not going to work, so you're going to need a fiber optic or trach approach. Going through that in order of use with a little patient story also highlights the idea that I've talked through my difficult airway plan, and it might be different per patient. So my airway or my equipment checklist in a patient I anticipate to be an exceedingly hard mask ventilation may be, I have my oral airway, but I'm not going to use that. I'm going to drop an LMA right away. And after that, I'll do DL to VL. I'll try to put a tube in. That won't work. I'll replace my LMA and use a bronchoscope exchange technique through the LMA. If that doesn't work, I'll call for a tracheostomy. Every time you do your equipment, it should review your difficult airway plan. Again, team, 2 airway leaders and assigned roles for everybody else that can be specific to your site of practice. Patient, what's unique about their physiology? Do they have LV failure, or are they hypoxic and their SAT is going to drop like a rock when you push medicines? What's their airway look like? Have you preoxygenated and positioned adequately before you go to sleep? Medications are grouped into safety pre-medicines, like a norepi infusion or fluid bolus, induction with etomidate, ketamine, or propofol, and paralysis with rocuronium or succinylcholine. Rescue medicines are really hemodynamic rescue medicines, like norepi infusion, epi, pushes, or a phenylephrine syringe. Finally, monitors, make them loud, make them frequent, and talk through your equipment in order of use. If we take each one of these things individually, when I think through a patient, I think of relevant physiology. Not that they have diabetes or not, although I love talking about diabetes. I think through what their heart's doing and what their lungs are doing, and maybe what their brain is doing too. Are they going to aspirate on you? Are they going to become vasoplegic the moment you push any medicine? Once I've talked through the relevant physiology, I want to do a quick airway assessment, and my airway assessment is really short. The first thing is I try to get an idea of their neck range of motion. The second thing is seeing if their mouth will open. And the third is that I look at them from the side. And that side profile assessment helps me get an idea of a thick neck or retrognathia or even a prior trach scar. As I'm looking at them from the profile side, I'm positioning them, and through this entire process, I'm pre-oxygenating them, again, with essentially as much oxygen as I can for as long as I can. Medications can be grouped. I've listed them here in a tabular format. Pre-meds are for safety. It's not midazolam for a procedural sedation. It's whether you need fluids, pressors, or maybe an epi infusion to keep the patient safe while you go to sleep. You induce with etomidate, ketamine, or propofol, and you certainly need to know the side effects of each and the dosing of each. If you don't have them memorized in your head or you don't use them routinely, these need to be available on a reference that you can look at quickly and easily. Paralysis with rocuronium or succinylcholine, of course you can reverse rocuronium even induction dosing, but you need Shigamidex to be near you. Succinylcholine, you simply have no business using if you can't list off the contraindications quickly and fluently, even under pressure. Many people can't list them all off, including esoteria like being bedridden for 7 days. If you can't list them off, you could kill somebody with succinylcholine. You have to know your contraindications before you use that drug. And finally, a rescue plan for if they have hypotension. And sometimes it's, of course, appropriate to talk about after sedation, after the intubation. Equipment is in order of use, and if you're in a pediatric environment or emergency department, you'll of course need reference sizing to be there and available or in your head memorized so you know the right equipment to have. I think of equipment in order of use, and I always include a safety check as I work through it. First, I'll grab a bag mask trauma bag. I'll make sure it has a PEEP valve and holds pressure, it has an oxygen supply to it, and that it's turned up all the way. Then I'll put an oral airway in because I can't bag mask the patient. They'll puke on that, so I'll need suction. Frequently, I'll set up 2 suctions for emergency intubations. After that, I'll try to intubate them with DL. That won't work, so I'll grab VL. I'll try to put a tube in. That won't work, so I'll grab an LMA or maybe a bougie. After that fails, I'm going to talk through a fiber optic or trach approach. Now I've done my safety check of my equipment, and I've talked through my difficult airway algorithm. And that's the TPMe checklist. Team, patient position preoxygenate, medications and monitors, and equipment in order of use. Knowing that will prevent you from having catastrophe happen to you out of the operating room where help may be delayed. Now, some of the questions I've gotten after giving this brief lecture is when and how I started using an airway checklist and whether I did that as a resident. I'll answer that by saying I didn't always use an airway checklist. I, in fact, started using a checklist when I forgot the LMA in my airway bag outside of a room and did an overnight intubation with a younger resident. And it took us a while to find the LMA. It was in the bottom of the airway bag. And in that meantime, I wasn't able to bag mask the patient, and they started having a lot of foam and nastiness coming out of their mouths. So they were aspirating, though not a horrible vomit airway. It scared me half to death, and I vowed to never allow that to happen to anybody else. I've used different iterations of airway checklists through my career. TPMe has become the easiest one to teach, and I do most of the teaching at my institution, and therefore or for airway teaching, I should be clear, and therefore I've arrived at the TPMe checklist. Next question I get is whether I've ever forgotten something in a code, and what was it? I've definitely forgotten things even on routine induction. When we practice in anesthesiology, we're sometimes supervising multiple rooms, and as you go from room to room, this requires a frequent resetting of your brain. What's unique about the patient in front of me? What can I not forget? What are they allergic to? And do I have the right medications in this room, even though I had them in the other room? In my career so far, I've caught missing phenylephrine, LMAs that were not restocked. I've caught DL lights that have blown between when the room was set up in the morning and when the case was happening, as in the light failed, and other things, of course. Now, in codes, we, of course, forget lots of things, and I rely on my checklist to not have it happen again. I've talked you through some. The LMA is the most horrifying thing that I'll never allow happening again. Now, I use airway checklists every time I intubate in every situation. I do it either in my head or frequently when I'm with a learner, I do it out loud. And the reason I practice that way is so that when I show up alone and it's 4 a.m. and I'm rolling out of bed in the call room to show up at a complex patient in the cardiothoracic ICU who's just had surgery, I have a fluent way that I do it every time. I talk through things every time, and that way when I'm tired, when things aren't going well, I simply don't forget things. The final question is how I assign roles in a code, since that takes up extra time. I would support anybody doing intubations assigning roles beforehand. The checklist that I showed in the table in this environment includes roles assigned. That's assigned to our respiratory therapists and our nursing staff in the ICUs I practice in. And so I don't have to talk through them, they're there. But we do have this card and checklist printed out in our intensive care unit. And so if people forget, those are their roles. Assigning roles takes extra time. I try to be really simple and assign things like you are in charge of drugs and physiology, you are in charge of the vent, you are in charge of the airway setup, and you are my backup person for the backup airway cart. Please don't leave that area, and I'll tell you what I need. Being simple is better in these situations. And that concludes my talk on intubation checklists. This is going to be part of a series of lectures on intubation in the critically ill. The next topic will be intubation experience, what you bring to the table as a person intubating, and what that brings to the patient in terms of risk. I appreciate your time and your attention. I hope you have a great day and a safe next intubation.